All right, so this starts our section on antimicrobial therapy. So what I'm going to do is the first set here, I have about 21 slides. They all won't take too long to get through this. And this is just an overview of antibiotics. As you know, that there are multiple classes of antibiotics, and so I feel that you really need to get an understanding of what they are, etc. So this is the first slideshow, so I'm going to get started here. Okay, so antimicrobials, if you've heard of chemotherapeutic agents, it's basically to kill off bacteria. So antimicrobials, it's another term for killing bacteria. Although you have, as we go through this, you'll learn that antibiotics don't just kill bacteria, they're also bacteriostatic. So they don't necessarily, aren't necessarily used to kill off the bacteria that's not supposed to be there. It may prevent the other bacteria from forming. So that's what we're going to go through. But it is used to treat infectious diseases, and they were first discovered in the 1930s and 40s from mold. So penicillin is actually one that's made from mold. There's some that are made from natural sources, such as mold, and then there's some that are made synthetically, chemically, that we put together as humans. And it has significantly reduced morbidity and mortality from infection. There used to be just rampant infections, epidemic of bacterial infections years ago, and so we had a lot of deaths from that. So thankfully, we do have antibiotics, although they're used appropriately and yet used inappropriately now, which is why one reason we have superbugs out there. And as you can see, we have 190 million doses are given each day in the hospital, which is a lot. As far as selective toxicity, this means that when you choose an antibiotic, you have to make sure that you're choosing the right drug for the bug. All right, so it means toxic to microbes but harmless to hosts. So what this means is that it's toxic to the bacteria, but harmless to the good cells. Also, there's another way that it works by disrupting the protein synthesis of the bacteria as well as the cell wall. So I did post a YouTube video that went through that. That helps you understand a little bit more on antibiotics, but there's different ways that antibiotics work. Also, it inhibits enzymes that are unique to bacteria. So depending whether it's amoxicillin, so that's your penicillin group, or a cephalosporin group versus a macrolide or fluoroquinolones, they all will work in a different way to reduce or eliminate the bacterial infection. And remember, these do not work for viruses. And as I mentioned before, so these work on the cell wall. So you have a bacteria cell, which end up multiplying into multiple bacteria cells. But these drugs work either by working on the cell wall, cell wall synthesis, so basically it breaks down the cell wall so it won't work anymore. Cell membrane permeability, again breaking down the cell wall in a specific way. Messing with the proteins inside the cell, which kills it. And also other ways of doing that that inhibit protein synthesis from happening. They work with nucleic acids, these antibiotics, within the cell again, antimetabolites, and viral enzyme inhibitors. So we're not going to really get into viral enzyme inhibitors, antimetabolites. You don't have to know these, but I need you to try to understand the concept that each class of antibiotics will work in a different way in the body to get rid of the bacteria. So this is a really important slide to kind of understand. So this kind of puts it in a nutshell. So it's either going to kill it or it's going to slow the bacterial growth of it. Okay, so think of it this way. Some drugs are directly lethal to the bacteria. All right, so you take the antibiotic, or you're getting the IV antibiotic, and once it gets to a certain level, then it'll kill the bacteria. There's some that are bacteriostatic though, so they slow the bacterial growth, but it's not necessarily going to cause the cell to die, but it's going to cause the bacteria to grow and basically damage it. Now we have some resistance to antibiotics. There's multiple reasons why, but in society now we are overprescribed antibiotics, we have superbugs, etc. So here's some ones with drug resistance, which you'll see in the hospital, and most likely you'll see more C. diff, and C. diff is a from actually overuse of antibiotics, clindamycin being the most common antibiotic to cause C. diff. That's the diarrhea. It has a distinct smell to it. It's something that you will unfortunately be around if you work in the hospital. You're on contact isolation. Also, there's these other ones here, like Staph aureus. Everybody has staph on them, but there's methicillin-resistant Staph aureus, so MRSA, in other words, that you will definitely see in your career, if not already. And so there's a list of antibiotics that are resistant. Ones that right now that we put people on in our community is Bactrim and clindamycin. But then with clindamycin, you got to watch out for the C. diff. But those are the first two options. And if patients are allergic to them, then you can go to a doxycycline. There's a whole list of them. A lot of these things that you'll see, for example, Klebsiella, Enterobacter, you'll see those in urine cultures. And what happens is you do the urinalysis, someone's coming in and complaining of urinary tract infection symptoms. You get a urine sample and they send it for culture. They put it on the medium and they incubate it for a couple days to see what grows out. And then what they do with whatever bacteria they identify, they expose it to a host of antibiotics to see which ones are sensitive and which ones are not sensitive. So what we found out is a lot of these common antibiotics that were typically used or is more first line for your common urinary tract infections now are resistant to Enterococcus, Klebsiella, Pseudomonas, that's another one also. So when I say you need to treat the bug to the drug, sometimes it's hard to figure out, well, what bug is for what. And as you go on in your nursing career, you are going to definitely get better at understanding that, okay, E. coli is the most common bacteria with UTIs. Elderly people, you will see more of the Enterococcus, because that's coming from the feces. You'll see more Klebsiella, you'll see Pseudomonas in urine with elderly people, just because they either are incontinent, some have Foley's, etc. And C. diff is obviously a overuse of antibiotic with the diarrhea. Staph can be anything from skin infections out in the community. Staph, you have to think of, there's community acquired and there's hospital acquired. Community acquired staph or MRSA. Let's say MRSA because it's resistant. Methicillin resistant, which would be penicillin resistant, in other words. You will see skin abscesses. In the hospital, you'll see anything from respiratory MRSA, in the urinary tract MRSA, and you definitely don't want people to become septic. So that gives you an idea of the drug resistance. So when I think of drug resistance, instead of, you can read yourself what's on the slide, but think of like just trying to think here. Okay, think of an M&M. No, don't think of an M&M. Think of a Hershey's Kiss. Okay, so that is a bacteria. Just pretend that's a bacteria. And for many years, amoxicillin worked. So you're taking amoxicillin and it's getting rid of this chocolate Hershey Kiss. Okay, that's the bacteria. Well, there's a couple things that have happened over time. Number one, the patient that's given the antibiotic, let's just say you have 20 bacteria of Hershey Kisses in your body, and you take only half the course of your amoxicillin. So you've only killed off maybe like 15 or 16 Hershey Kisses. We still got 4 bacteria left in your system. So what do? They start multiplying, okay? And what they can also do is morph into something else. So that then may become like a, let's see, what does the Hershey Kiss turn into? Let's say it turns into a Reese's Pieces, okay? So now it's become more of a superbug. So now when you take the amoxicillin again, it's not going to kill it off, because now it's gotten stronger. So basically what happens is these bacteria outsmart the antibiotics. So that's one reason why that can happen. It's the overuse of antibiotics. So that's why it's really important to make sure that patients are taking all of their antibiotic like they should, but most importantly, that we're not just giving it out like it's candy. For example, azithromycin, that's a Z-Pak. I'm sure all of you have heard of a Z-Pak. It's very, very resistant. Actually, this area is resistant. We shouldn't really be prescribing it, but we still are prescribing it. All right, so antibiotic use in drug-resistant microbe emergence. So drugs make conditions favorable for overgrowth of microbes that have acquired mechanisms for resistance. So again, the drug is overprescribed. You're taking the drug, you're not taking it as prescribed anymore. The other thing to know, so antibiotics that promote resistance, broad spectrum agents do the most to facilitate the emergence of resistance. So we have narrow spectrum antibiotics and we have broad spectrum antibiotics. What that means is broad spectrum antibiotics can kill a host of different types of bacteria. So, for example, if you come in and you have, let's just say you have like a cellulitis on your ankle and we're not really sure what it is. So what will happen is most people, we try not to do this. We want to try to do a narrow spectrum, meaning if we know what the bug is, we're going to treat the bug with the right drug. So let's just say it is a MRSA. If it's a MRSA, I am going to give something specific for that MRSA. If we're not really sure what it is, we will go ahead and say, all right, well, let's just treat with an like a amoxicillin. That's a broad spectrum antibiotic, meaning it can work on urine, it could work on respiratory, sinus. It's broad. So that has brought on the emergence of resistance also of using broad spectrum antibiotics just for pretty much anything. So we have to really know what we're treating. Also, the more antibiotics are used, the faster drug resistant organisms emerge. There's kids that get ear infections, and some physicians and NPs, PAs will put them on antibiotics over and over and over again. So my rule of thumb is always, and there are guidelines out now that a lot of these ear infections will end up going away. I am not talking about chronic ear infections with drainage and perforated eardrums and that you have to put tubes in. Not talking about that, but just your run-of-the-mill. A lot of these are viral or they will end up going away on their own, so you just have to watch them. Because the more antibiotics you take as even a child or an adult, you just run the risk of having antibiotics not work as well as you get older. There's also healthcare associated infections and then the super infections. And the super infections are ones that are like VRE is a super infection. So it's hard to treat that. So these are ones that really, like vancomycin's like the only thing that will work for super infections. All right, so how do we prevent this? Well, appropriate prescribing guidelines, as I mentioned, and reduce demand for antibiotics, which I mentioned that also, and please adhere to the prescribed antibiotic regimens, because then you're going to, if you don't do this stuff, I rarely take an antibiotic. I will go like a month before I'd even think about taking one. Viruses can last that long too. I'm talking about respiratory stuff. 99% of bronchitis is virus, but people just don't understand that it is. I want antibiotics to work for me someday if I need it. You know, what if I become septic? What if I end up with something where I need antibiotics? I want them to work. I also want my patients to take them as prescribed, because I don't want them to stop taking it and the bacteria not be completely gone. Even if they feel better, they still can have some bacteria in there, and then it starts exploding into a superbug. Like basically the bacteria morph into something greater and counteract the antibiotic that you're taking. Oh, I'm not going to work with you anymore. So they win. The bacteria wins. So there's different public health actions that we're doing, which I'm not going to go through, and this will not be on your exam, but just know that there's a lot of public health stuff through the CDC, other organizations to help combat that. So how do we select our antibiotics? We have to identify what the organism is. Now, so this would be good to just try to understand when you're inpatient in a hospital, how the physicians are picking their antibiotics for people. Why are they putting them on levofloxacin? Why are they putting them on Zosyn, etc.? The drug sensitivity of the organism, host factors. Drug may be ruled out by if they're allergic to it. It's not a good infection, or just different variables. Maybe the patients had some sensitivity to that specific antibiotic. If you've heard of, it's called TARASCON, antibiotic guide. There's Sanford guide. That's probably the most popular one used. Sanford guide to antimicrobials. Most physicians will use a Sanford guide to determine what is first line. And there's a new publication that comes out every year. There's a pocket guide that you get. So if my patient has, let's just say strep throat, I can look up strep throat in there, and it'll tell me what the first line antibiotic is. It'll tell them what if they're allergic to penicillin? What am I going to go to? Because first line's PenVK, penicillin. What's the next one going to be, etc. So while we as providers know most common things what to treat, there's a lot of things that we don't, and we have to look it up. Let's make sure that it's still in the guidelines as first line. For example, first line antibiotic for sinus infection always was amoxicillin. Now that's changed to Augmentin, and it's because of the resistance issue. All right, so that's how you select an antibiotic. So empiric therapy means, let's just say someone comes in and there's pneumonia identified on the chest x-ray, but you don't have a sputum sample, you're not really sure what you are treating exactly. So that's empiric therapy. So you're giving it to patients before the causative organism's positively identified. So you know you got to treat this pneumonia, so you put them on more of a broad spectrum antibiotic based on lung infection. So they'd probably put them on a Levaquin IV drip, or they could send them home if they're in the ER, depending if they're not really sick, or septic protocol is not good, etc. So just so you know, that's what that is. Same with urinary tract infections. I have a patient come in the office. They have a urinary tract infection on their urine dip, meaning they have leukocytes, bacteria showing, but I don't know what the organism is. So what am I going to do? I'm going to pick more of a broad spectrum antibiotic, although narrowed, because I do know that first line is macrobid for uncomplicated UTIs. So I will give some macrobid, send it for culture. There could be a case where it's resistant to the macrobid. Then I will switch the antibiotic. So match the drug with the bug. That's done by gram stain. You do the culture and sensitivity, and they do this all in the lab. There's all different factors as to how you're also going to pick it. Like, how's your immune system? Where's the site of infection? Do they have previous allergic reactions? Genetic factors. I guess, like, if everybody in your family's been allergic to penicillin, you're not going to take penicillin. I would probably try to shy away from that. So dosage, size, and duration. Well, how much are you going to give and how often? So again, you're going to use your drug book, okay? There are most common dosing and duration. So the antibiotic must be present at the site of infection and for a sufficient length of time.
Don't discontinue prematurely. And then again, this is common sense to complete the full can't even talk tonight. The full prescription. There's some combinations of antibiotics, which we'll go through. Especially inpatient antibiotics that are combination. There's prophylactic use of antibiotics. Now, prophylactic means to use to prevent infection. They're only used to prevent infection if they're going to surgery, if their white blood cell count's low, either immune system's low, or bacterial endocarditis. So if you think they have a bacterial endocarditis, then you would treat prophylactically to prevent infection. Endocarditis means inflammation. It doesn't necessarily mean they have a bacterial infection, but we're not really sure. So we're going to establish it as bacterial endocarditis and give an antibiotic. We really have no, maybe we didn't talk about this. Okay, misuses. Treatment of viral infections. This again is going back to overprescribing. Treatment of fever of unknown origin. We don't know why they have the fever. Could be a virus, but we have no idea. And then you just give an antibiotic. Let's see if it goes away. Not giving the right dosage, and treatment in the absence of adequate bacteriologic information. Like your UTI, and we don't know what bug we're treating. We're just treating a UTI. So you obviously want to monitor if they're getting better. There's some antibiotics where they do serum drug levels, like vancomycin peaks and troughs, and there's other ones that are more inpatient. We don't do that for outpatient. It's more some of the IVs, the more serious ones. So you want to obviously see if they're getting better. Are they having any sensitivities to the antibiotic? All right, so I went a little bit over time than I wanted to, but that's kind of an overall of antibiotics.